Very interesting. Yes,
Thank you,
Dr.
Dr.
Pawan,
Jess.
start. You are audible.
Yeah. Thank you, Dr. Jess. Now we would like to move on the last session of today. Sacro-iliac fixation is not so routinely performed procedure like other spinal fixation surgery. It's somehow tricky and requires impeccable surgical skills. Knowing the art of this fixation surgery certainly makes us a complete spine surgeon. In continuation of that, it's my honor and privilege to invite our eminent panelists for the sessions. The first panelist is Dr. Altaf Ramjan, Professor and Head, Department of Neurosurgery, Sher Kasmi Institute of Medical Sciences. Dr. Guru Raj S, Consultant Spine Surgeon, Indian Spinal Injury Center, New Delhi. And Dr. Gautam Javeri, Consultant, Fortis Hospital, Mulund. To proceed further, I would like to invite our first speaker, Professor Deepak Singh. Professor Deepak Singh is currently Professor and Head Department of Surgery, RML Hospital, Lucknow. Dr. Deepak, sir.
Thank you, Pawan. I think our video is pre-recorded, so maybe you can run it.
Sure, sir.
In continuation with the previous anatomy lectures of the spine models, now we are going to talk about the relevant bony and radiological anatomy for putting up the iliac screw and the sacro-iliac fixations. It must be remembered and tried that whenever possible, this sacro-iliac fixation should always be tried in conjunction with the putting of the S1 screws. L5 S1 interbody fusion should also be tried whenever we try to put the iliac screws, because this screws increases the fusion rate by 80 to 95%, and they reduce the strain on the S1 screws by a factor of 70%. Though the experienced surgeons try to put and always put these screws by freehand technique, but for starters, they must learn the few radiological views for putting up these screws. The basic views that are required for putting up these iliac screws are the lateral view, the obturator outlet views, and the obturator inlet views. That will describe later on when we try to put this screw on the bone model. So this is the basic sawbone model of the pelvic girdle, which basically is made up of a strong triangular bone, that is the sacrum, and two hip bones. This hip bone is basically made up of three bones: the ilium, the ischium, and the pubic bone. All these bones join here to form this cavity that is called as acetabulum. This hip bone is basically has four borders: the superior border, the posterior border, the anterior border, and here lies the medial border. The superior border runs from this bony projection that is called as anterior superior iliac spine to the posterior superior iliac spine. The posterior border runs from posterior superior iliac spine, then there is a posterior inferior iliac spine, then there is a major notch that is called as greater sciatic notch, then the ischial spine, and the lesser sciatic notch. The anterior border runs from anterior superior iliac spine to anterior inferior iliac spine to the acetabulum. These borders are of main interest for putting up the iliac screws. It has three major surfaces: the gluteal surface, the iliac fossa, and the sacro-pelvic surface. The sacral surface basically forms the sacro-iliac joint along with the sacral bone. So first we talk about the exposure for putting up the iliac screw and set S2 LR iliac screws. For craniocaudal exposure, the caudal exposure should be up to the dorsal S3 sacra foramina, and laterally it should be up to the posterior superior iliac spine. While exposing the sacral foramina, one must remember that these sacral foramina are the exit of the medial cuneal nerves. So when we try to expose these foraminas, there are chances then later on the patient have the sensory loss over the buttock region. So to prevent this, what we can do, we can leave a cuff of muscle over these foraminas, but in practical life usually it's not possible. So one complication of putting up these screws of loss of sensation, partial sensation over the buttocks. So our caudal exposure should be up to the S3 sacral foraminas and laterally up to the posterior superior iliac spine. There are two basic entry points for putting up these iliac screws, one through the PSIS and one is the recess screw. The PSIS screws, once one put directly through this PSIS after putting a trough or creating a trough here, because these screws tend to protrude through the skin, and that is a source of major morbidity, like in 18% of the cases in the post-operative period. So first we used a 3 or 4 mm drill bit and create a trough here so that the screw head can be embedded inside the bone, and from here one can use a gear shift probe. So for using the gear shift probe, our basic direction of putting up these screws is, one must remember that for all these iliac fixation, the basic direction is towards the AIIS, the anterior inferior iliac spine. So where you are putting the traditional iliac screws, the recess iliac screws, or the sacro-iliac fixation, the direction is always towards the anterior inferior iliac spine. And the basic structures that we want to prevent are, we must not enter inside this greater sciatic notch, we must not enter inside this hip joint. So these two important structures has to be avoided at any cost, and that's the basic philosophy of putting up the iliac fixation. So for traditional iliac screws, we start from here, that through the PSIS after making a trough, and by using a gear shift probe, we go directly towards the AIIS. We have to use this part of the bone, the 2 centimeter above, the part of the bone that lies within the 2 centimeter to this greater sciatic notch, because this is the thickest bone. This bone is the thickest bone. So we must try to remain within the 2 centimeter of the greater sciatic notch. We start from here using this gear shift probe. We go towards the anterior inferior iliac spine. So that is the basic technique for putting up the traditional iliac screws. For putting up the freehand screws, we must try to locate the greater trochanter on the table. We must palpate the greater trochanter and we must try to remain above the greater trochanter. So by this way, we will always remain above this acetabulum. The ideal length of this iliac screws is like 110 to 140 mm, but in practical life, we should put a shorter screws like 100 to 110 mm, so that automatically will prevent entry inside the acetabulum. For preventing your gear shift probe or screw entering into the greater sciatic notch, there is a practical aspect that we can remove a bit of the gluteus muscle from this surface and we can directly palpate the greater sciatic notch while putting up the screws. So by this technique, you know that you are not entering inside the greater sciatic notch. Feel the greater trochanter over here and go in that direction. You can see that is like 40 degree in the horizontal plane and like 40 to 50 degree in the vertical plane. So that is our traditional iliac screws. To prevent the complication of the screw head protruding through the skin, there is a modified technique that is called the recess screws. When we expose this part, of the sacro-iliac joint. The recess screw is 1 centimeter deep. The recess screw is 1 centimeter deep to the traditional entry point. It lies somewhere here, deep within the bone. Again, the things are same. From here, it will have a flatter trajectory. From here, this is the second entry point for putting up the iliac screws. From here, again, you have to remain within the 2 centimeter of the greater sciatic notch that you can palpate directly. You can palpate directly during the surgery by removing a part of gluteus, and just have a knowledge of this slope. Just have a feel of this slope during the surgery, and using the gear shift probe, go towards the AIIS. Go towards the AIIS. Again, the length is same. For male, usually 8 to 9 mm screws. The length is 110 to 140 mm. This is about the iliac fixation. So, for connecting these iliac screws to the sacral screws, one has to use the offset connector. That offset connector itself will reduce the strength of the construct by 15 to 20%. And secondly, since these screws has a chance to protrude through the skin and post-operative pain, the S2LR iliac screw comes into practice. For putting up the S2LR iliac screws, the entry point lies somewhere here between the S1, S2 foramina. One must first mark the S1 foramina, the S2 foramina, and from their lateral borders draw a line, and lateral to this line, we can use this bone, this thick quadrangle bone, for putting up the S2LR iliac screws. This whole bone can be used, but the traditional or the practical entry point is first mark the entry point of your S1 screws that lies somewhere over here on the inferolateral aspect of the joint, and then in line with that mark your entry point of S2LR iliac screws, so that it will be easier to connect through a rod later on. So between the S1, S2 foramina, lateral to it and in line with the S1 screws, here lies our entry point of the S2LR iliac screws. So again, using a 3 to 4 mm drill bit, make an entry point, and using a gear shift probe, one has to, the trajectory remain the same, but it will be lot flatter. The trajectory remain the same. One has to go through this sacral bone, and at the length of around 2.5 to 3.5 centimeter, you will enter into the SI joint. Then again penetrate the cortex of the iliac bone. Try to remain within the 2 centimeter of the greater sciatic notch and go towards the AIIS. So this is about the S2LR iliac screw fixation. These screws are a bit shorter. In practical life, it is like 90 mm to 110 mm, and the ideal width is around 7 mm in female patient and 8 to 9 mm in male patients. This S2LR iliac screw has the advantage of remaining in the line of the S1 screws. They have less post-operative pain and less chances of failure. But since it crosses the SI joint, so there is a theoretical possibility of SI joint pain later on. To overcome this problem, some companies has designed special screws for putting for this S2LR iliac fixation that have a proximal smooth shaft with holes inside through which you can put hydroxyapatite for SI joint fusion. So this is about the S2 LR iliac screws. So coming to the radiological views, when we start putting our iliac screw or the sacro S2 LR iliac screws, we should start first in the lateral view. That will dictate our direction for preventing the greater sciatic notch. So you just start your screw trajectory in the lateral view, and when you are sure that you are not entering inside the greater sciatic notch while using the gear shift probe, then change the direction into the obturator outlet view. So this is our basic obturator outlet view. For making this view, there's a very simple thing. You just put your C-arm, you can put your C-arm in the direction of your probe, that is parallel to the direction of the probe, parallel to the direction of your screws, and just using your gear shift probe go towards the AIIS. So we switch to the C-arm first and we look how it is there on the fluoroscopy. So this is the basic fluoroscopy view of obturator outlet view. In this view, we can mark a teardrop. This is the teardrop structure, which basically comes from putting the PSIS and AIIS into a line. So this is our trajectory for putting up the iliac screws. Here is our gear shift probe. This is screws for joining the model, so just don't look for it. So your gear shift probe should start in the center, in the inferior part. So we can see we are a bit higher. So we have to remain within the inferior part of this teardrop, and we have to go directly. The end on appearance should be there after putting up the screw. This is the basic obturator outlet view. So we now have put our iliac screw, and you can clearly see the end on appearance of this screw in the obturator outlet view. This is lying right now in the center of this teardrop. So it is not going inside the greater sciatic notch and neither into the acetabulum. So this is the another view that is called obturator inlet view, that is basically perpendicular to your iliac screw, just opposite to the obturator outlet view, perpendicular to the iliac screw. This will clearly show that your screw lies within the iliac bone, not going into the iliac fossa or neither breaching the outer iliac cortex. This is the fluoroscopy view of the obturator inlet view, where you can see that your screw is lying within the iliac bone, neither going outside or the inside into the iliac fossa. So these basic views, the lateral view, the outlet view and the inlet view, the starter can use for putting up the iliac screws safely. So depending on the requirement, you can put either the traditional iliac screw, the recess iliac screw or the S2 LR iliac screw. But only word of caution for putting up these screws is that you should always try to put this screw in conjunction with the S1 screw and L5 S1 interbody fusion wherever possible. This is the only word of advice from my side. So this concludes the basic anatomical and radiological session of putting up the sacro-iliac fixation. We will continue with the other presentations. Thank you.
So I think this is the basic presentation regarding the bony anatomy and the radiological anatomy for doing sacro-iliac fixations. And as I have said, these screws should always be tried along with the S1 screws, along with the sacro fixations, and that will give the maximum advantage. We'll, I think, continue with the next presentation, then we can take questions.
Thank you, Deepak sir, for your wonderful presentation. Thank you, Deepak sir, for your wonderful presentation. You have described very well the importance bony landmarks, morphometry of bones, various entry points, different technique for sacro-iliac fixation, and some few very important tips to avoid the potential complications during the surgery. Now it's time to learn the sacro-iliac fixation by viewing the surgical step in vivo. So I would like to invite our last speaker of the day, Dr. Ranjit Unnikrishnan. He is a consultant spine surgeon, KIMS Hospital, Trivandrum, and he is going to present a stepwise surgical video regarding the sacro-iliac fixation. Dr. Ranjit sir, please.
Thank you very much, Dr. Pavan. I'm doing a live. This thing, is my screen visible? Can you see?
Yes, sir. Yes.
Thank you very much. Thanks for the invitation, the entire team at SGPGI. Thanks, Dr. Deepak, for a very excellent presentation on the bone model. So I'll just take a quick to a couple of key steps and then go to the surgical video. So what are the absolute indication for this? An L5S1 when it's source of whole fusion, or a long segment fixation, oblique takeoff of L5S1, or when you have a previous or a laminectomy at L5S1, which will lead to a lot of instability prior. So these are the real indication. When you expect significant biomechanical stresses at the lumbosacral junction, long fusion to sacrum, by long meaning more than 4 levels, and in osteoporotic bone. Now, I'll not go into the detail. Dr. Deepak also mentioned about all these 3 segments. So we know that zone 3 is where we have the maximum amount of strength. So this is how the evolution of the sacro-iliac fixation has gone, and we have come and ended up at S2AI when Carl Kabaish team described this along with Ponceller in the 2007s. Now, I typically use a Mercedes-Benz incision when I do these approaches because it gives me a real lateral access to what Dr. Deepak mentioned in the last bone model. I really have to see the ilium. I have to see the sacrum well to get my entry point right, because I typically do it freehand. I have no navigation, and I think it can be easily done with freehand along with just a C-arm when in doubt. So this is exactly how it goes. The biggest advantage is that when you connect your rod to the iliac screw, you don't have to have any lateral connect, etc. So that helps a lot in your fixation. So like what the previous speaker mentioned, the starting point is between S1 and S2. I use a drill, a long 2.5 millimeter drill, and this is the trajectory. Now let us see in the real patient, how do we come to know these landmarks? For me, I have to always feel the tip of the trochanter, because the AIIS is very difficult to feel in a patient when he's prone, especially if the patient is obese. So I have to feel the tip of the trochanter. I make sure I can feel it. And this is my trajectory. So again, I'll not repeat all the steps what was mentioned here. For the want of paucity of time, we're already late by 2 hours. So this is how all the steps go. You have to get to your the previous speaker also mentioned about the right view, how to see this. Now, this view is important if you want to see your obliquity very well. Now, this view, let me tell you, it's not always possible unless you were totally radiolucent tabletop plus a very sensible C-arm technician who can do this. If not, it's actually not very easy to get this view in drop. Now, this is to be very, very important to this point. The screw path has to be above the sciatic notch. So the most of the times, if you're not very used to this thing, one of the common error is to violate the sciatic notch. It should be as much as possible close to the sciatic notch. That is where the fluoroscopy is helpful. And I typically have not used 100 in our patients. I try and always use a 8 millimeter diameter screw with 80 to 90. The max I've used in our patients is 90 millimeter, even though Europeans and North Americans have used 100, 110. I have not used more than 80 to 90 in my practice, and I always use a 8 millimeter screw whenever possible. In child, it is 6 millimeter. Now, what are the effects of this screw on the SI joint? There is no evidence of any SI joint fusion happening after a sacral screw. There is no change in the joint space. There is no significant SI joint area pain also. This has been reported in literature. Now, if you happen to read this article, you will be very, very scared putting in a screw. Thankfully, I read this article after I learned how to put the screw. This tells all the vital structures near on the trajectory of the S2AI screw. So this is just to know what all can go wrong, but I say not to go through it too much. So I have taken two of my extreme of patient. This was my most elderly patient whom which I had to put an S2I. This was a 71-year-old physician with severe back and leg pain who had a Regents coli or an adolescent coli which presented Regents coli and was wanting a fusion because he was significantly affected. This is where we went ahead and did a long T2 to ILM. And the next is this is a long-term follow-up. This is another patient which we did recently who was a 6-year-old child who had a developing high-plastic listhesis who came in with a Cauda-Equina syndrome. The child came with a Cauda-Equina syndrome. It's quite obvious in the X-ray and MRI. So we had to go ahead, do a sacral dome resection. And in that case, it was too small. We couldn't just rely on the sacral screw. So went ahead, did a S2AI. This is by far my youngest S2AI fixation, a 6-year-old child, wherein we use we use a 5 millimeter 50 millimeter screw, which was the longest available in that particular instrumentation to do this fixation. So with this, these are the concerns when you do the fixation. Does it cause any motion issues, etc.? Does it autofuse? So what the common pitfalls are? Do you always need an S1 screw when you do a S2AI? The previous speaker did mention it's always a good idea to have an S1 screw whenever you do an S2AI. Having said that, there are situations where it is not possible to get in both together. In adults, it's always possible. You always try and get it. In a child where you cannot put an S1, it's okay, but always at least have 2 screws. Personally, I always prefer bilateral S1 and bilateral L5 as well as S2AI. One of the common pitfalls, well, you started your screw, it does not pass. The most common thing is that you've got a long trajectory because your entry point cannot go wrong because it's seen under vision. You really go and hit the lateral cortex. At that point, you have to pull out the trajectory and make it more vertical, and that's how you get with this. With this, I will I'll just go to the video. Sorry, this is a video from my boss from whom I learned this technique. I hope it is. Can you see the video? Is the video seen? Dr. Pavan?
Yes, sir.
Yeah. So this is standard. So I'll go with the narrative. For want of time, we'll not spend much time for this. Classically, this is Dr. Kebai from whom and sponsor from whom I learned the technique. So this is classically the mention which the previous speaker mentioned. You have to make sure. So this is where I use the Mercedes-Benz approach. When I use a Mercedes-Benz approach, I can see that I can really see this foramen, S1 foramen, S2 foramen well, and also I can really angulate my screw into the right direction. Another tip of what I follow is that you can always put a finger in this part of the iliac crest. To know the orientation, you get your entry point right. You have to get your inclination right. So I expose the PSIS, feel that's lateral cortex of the ilium. I feel the lateral cortex of the ilium. So that gives me the angle of my awl. That's how my awl is angulated so that I can really go parallel to the ilium. That gives me the right angle to go inside. So this is how you go about it. You put in the S1 screw, like the previous speaker mentioned. Always make sure you have the S1 screw. That helps you to get your straight line or to get in your rod. You nibble off the soft tissues. You have to really use a cautery well, clean it well. Make sure that you see the entry point, you see the S1 notch, S2 notch well. And this is where you have to angulate. Like I said, you can always not feel the AIIS. So I air it towards the tip of trochanter. This is another important point. You have to know the plane of the sacrum. So the way we say, forget the world, just remember this flat piece of bone. This flat piece of bone, you should be absolutely right angle to it in the sagittal plane. So that gives you the orientation depending upon the obliquity of the sacrum. So you cannot really make out where your sacrum goes. So you expose the S1 hole, expose the S2 foramina, find the flat piece of bone which Dr. Kabaish is right now showing, and your drill should be, your awl should be right angle to it in the sagittal plane, and you put your finger on the lateral aspect of the ilium, and that gives you what is your angulation of your drill. So you get 3 of your landmarks right. You get the right entry point, you get the right inclination, and you get the right sagittal orientation. Once this 3 is correct, I typically use a nibbler part of the bone, and this how he taught me to look at the trochanter, tip of trochanter, not to, AIS is somewhere around there. So once you feel the tip of trochanter, you should be able to feel it, and this is your trajectory. So I typically take in my entry, put in my drill, and then I take an APCM shoot. My idea of I can feel my inner and outer cortexes very well when I go inside. So at that, hence, I don't really want a CM there. What I want to see a CM is to make sure that I'm not going into the sciatic notch. I'm not going to sciatic notch. So at this is where the entry point is made, right angle to the sacral bone out here, and then next is the drill. So the drill is used in a stop start mode. I use it in oscillating mode. So that gives me a good control of the drill, and make sure you use a long 2.5 drill. If you use a short drill, it will hit the opposite side buttock and you will not be able to advance it well. So this goes in like this. You feel it. Each step you have to feel. The drill is like the tip of your finger. So you try to feel the inner and outer cortex, and after it goes in, this particular why the previous doctor also showed it very nicely. You have to have it tilted. If you have a very good C-arm tech, this is very easy to get. The oblique is where you get a bit of to get the real teardrop is where you have a bit of difficulty. So, but I say that once you have your trochanter palpated well and use a drill like a feeler, you have to feel both the cortices. You will first you'll get a soft give way. That's where the sacrum is drilled. Then you find the SI joint resistance, and this is the point you have to make sure that my drill is above the sciatic notch. All my errors have been I've gone either too close to the notch, and other thing is not to push the drill too much, because if especially in an elderly patient, the notch, I have blasted the notch by pushing too much. So you should be very careful at that point. If you struggle somewhere, just stop, take a CM shoot. If you're not struggling, go ahead smoothly inside it, and you can go ahead with it. And I typically, in our patients, I have not had to always tap or just tap the entry point and then go ahead and put the screw. So for want of time, I'll forward the video. This is it, and it's really you will get a really good purchase of this, and you can typically pull the whole patient with the screw. And many a times in our patients, you will have to cheat a bit, meaning you have to keep screw a bit inside or outside to get it all aligned in the same line. And it's always ideal to use a thick screw. Most of our patients can very well take a 7.48 screw around 80 millimeters, and a rare thick built guy will take a 90 millimeter screw. So putting the S1 screw first gives a good idea as to where you should stop, and you will have to have a bit of difficulty to get in your rod aligned well, because you'll have to pull out, take it out, or take it in here and there to make sure that your rod gets aligned very well. So this is it, and with this I'll stop my share, and I'm ready for any questions. Thank you.
Thank you, sir, for your stepwise and so detailed descriptions. You have shown nearly all crucial steps of surgery with emphasis on what to do and what not to do. I hope we all have benefited by your excellent video. Now it's time for the question answer session, and the first question to the Altaf sir. Being a so extensive surgery, sir, there is a lot of post-operative pain in these patients. So what kind of post-operative analgesia would you like to prefer in these patients, sir? The first question, sir. Sir, your voice is not coming, sir. We are not getting you. Altaf, sir?
Yeah.
Please mute and
Yeah.
unmute yourself.
Yeah.
Yes, sir.
So general painkillers like NSAIDs, they can be tried because there's a lot of cutting and drilling. So most of the patients should be, because if there is because neural injury is not there, of course, it's just a soft tissue. So that should be helping them.
What we do whenever we go for long segment fusion, we used to place epidural catheter, and for post-op period, one can use the epidural infusion of fentanyl infusion several times.
Gautam, sir? Gautam, sir, please unmute yourself. You may answer this question, sir. Would you like to comment on this?
On the pain relief?
Deepak sir has asked questions, sir. Actually, Deepak sir, may you ask again, because your network connection is very poor, sir, so that's why we are not getting.
What I have said that for any long segment fusion, what we used to put up.
Dr. Deepak, you are not audible.
Yeah. Now am I?
Yes, fine.
Yes.
Can you listen me right now?
Yes, exactly.
So what
you go ahead, sir.
We used to, what we used to do for any long segment spinal fusion, or where we expose a long segment of a spine, we used to put epidural catheters for 24 to 48 hours, and from that we can use fentanyl and other analgesics for 24 to 48 hours, and most of patients that will settle the pain.
Thank you, sir. Thank you, sir.
That is very good, actually.
Yes, sir. Second, the next question to the Dr. Guru Raj.
Yeah.
Sir, is the neuromonitoring is really helpful in sacro-iliac screw fixation? If yes, then what kind of neuromonitoring we have to use? Is the next question in the chat box, sir.
Actually, if you're doing in a normal case where there's no deformity, you're not doing any deformity correction and all, so you don't need a neuromonitoring in a sacro-iliac fixation.
Yes, sir.
So only thing you have to be sure is that you are above the sacro-iliac notch. Other than that, you don't need a neuromonitoring when you do a sacro-iliac fixation.
Right.
Okay, sir. One more question is to Altaf, sir. The question is, what is the quality of life, particularly for young and athletic group of patient after sacro-iliac fusion?
I think if the fusion is done nicely as shown, they usually have a very good life. Even there are sports people who can go back after good rehabilitation. They can go back to their activities.
So can I come in?
Yes, please.
Actually, sacro-iliac fixation and fusion are two different things. So when we talk about these, we have to be really basically sure and don't mix these words. Sacro-iliac fusion is different and sacro-iliac fixation is different. So as actually I think it was Ranjit, Dr. Ranjit was mentioning, it is when you do a S2AI screw, it usually doesn't fuse. It's just a fixation. It's not a fusion.
Okay. Sir, one question from my side, Altaf sir. Sir, as a neurosurgeon, we used to tackle lots of sacral chordoma. And sir, what is your experience of sacro-iliac fixation after excision of sacral chordoma, sir?
Total sacral.
Yes, sir. After total sacralectomy or after.
Then fixation has to be at least a 4-rod fixation would be better in those cases because a lot of load is there. and that should be helpful. The simple fixation might not be helpful, so at least two rods on two sides to parallel. So that would, and even a cage along with that should be more helpful.
Jayesh, Anand side. I
Hello.
think I think sacral chordoma is one of the indication in which you need to put a direct iliac screw, because sacrum might not be available for S2 LR iliac screw. So that is one of the indications. Not only sacral chordoma, any sacral tumor in which there is destruction of the body of the sacrum. Then in that case, you have to go for an iliac screw directly. You cannot have the much more stronger S2 LR iliac screw. I think Dr. Gautam and Dr. Ranjit can and Dr. Gururaj can further elaborate on that.
Actually, there is one more indication where you have to put only iliac screw, not S2A. There's something called as kickstand screw when you correct neuromuscular scoliosis. So it's not a completely kind of a iliac screw, but the whole screw is in the ilium, and you use these screws to basically correct the coronal imbalance in these patients.
Similar question asked by Professor Sanjay sir, and he wants to know exact indication of involvement of sacro-iliac fixation in deformity, sir. Zaveri sir and Gururaj sir, can you take this question?
In spinal deformity surgery, the most common place where one uses a sacro-iliac screw is basically in patients with adult degenerative scoliosis, where you're doing multiple level decompression and a long instrumented fusion which goes down from D10 to S1. So in these patients, one does a sacral screw to reduce the risk of loss of fixation or pull out of the screws above. So in the adult population, that is the most common indication. Where deformity is concerned, the most common is patients with a significant pelvic obliquity. Children whose pelvis is oblique like this, and as Gururaj mentioned, you wanted to correct this coronal plane obliquity of the pelvis. That is where you would use a pelvic screw fixation. It could of course be used in any patient who does not have very good bone quality. You could use it in high-grade spondylolisthesis in children, as Dr. Ranjit just showed in that case where the 6-year-old he used it. I have used in children, in patients who have had failed sacral fixation following previous surgery where there were a spondylolisthesis was corrected, only fixed up to S1. The screws have pulled out and the whole deformity has recurred. Then we tend to extend a fixation. Also in children with lumbosacral kyphosis because of tuberculosis, sometimes the upper sacral end plate, S1 end plate, is eroded because of the infection. And in these cases, the additional stabilization going into the ilium is very, very useful.
Right.
I hope that answers the question.
Yes, sir. Dr. Gururaj, would you like to add in?
And only other factor which Dr. Gautam sir mentioned is any lumbosacral junctional problems like tumor, infections, where you need additional fixation into the distal part. So you'll have to do S2AI or a iliac fixation.
Pawan, in many more questions? Any more?
Yes, yes, sir. The next question to the sir Ranjit sir.
Yeah.
So Ranjit sir, apart from the long segment scoliosis fixation for the scoliosis and the high grade listhesis, there is a sacro-iliac fixation for the low backache originated due to the SI joint pain, untreatable medically refractive SI joint pain. So, sir, what is your view regarding the SI joint pain and requiring fixation for that?
Yeah, Dr. Pawan, this is two different animals. When we are talking about S2AI fixation or SI or sacro-iliac fixation as a part of deformity or degen, and when you do a SI fixation with respect to pain, they're totally different.
Yes, sir.
The first part has been discussed by Dr. Zaveri, Dr. Gururaj, and Dr. Altaf. For me, there are two conditions. I see them into two parts: a listhesis or a deformity. A listhesis, a high-grade listhesis for me is a deformity surgery. Grade 1, grade 2 listhesis for me is a degenerative surgery. In degen surgery, I never do a S2AI fixation because it is not warranted. You can do a short segment L4, L5, or L5S1, put in bicortical screws, interbody at L5S1, and that is enough. You don't have to go in for a major or a more radical S2AI fixation. When I do a high grade listhesis, irrespective of age, might be a child or an adult, wherein I am going to do a sacral dome osteotomy or some kind of partial reduction, that is a deformity surgery for me. A deformity surgery for me has to have at least 2 above, 2 below fixation. So when I come to that situation, if it is L5S1, I can have 2 level fixation below only if I get 2 S1 screws and 2 and a S2AI. There's no doubt about it. These cases, I will definitely put a S2AI along with L5 screws. When it comes to a adult deformity surgery, I'm using this adult deformity. Generally, we have to operate not for deformity, but for pain. So therein, I have to have a solid foundation. There, I look at it in 3 ways. Number one, I always want to get an L5S1 interbody cage inside. If it is less than 6 millimeter disc space, where I cannot put in my smallest cage, then I will get bicortical screws of S1 and always a S2AI fixation. If the anatomy precludes an S2AI fixation, then by interbody at L5S1 and bicortical S1 screw. That seals it for me. And I'm yet to see, I am doing S2AI since last 8 years. My longest follow-up is 8 years. From 71 years to 6 years of age, I got follow-up. I have yet to see a single S2AI SI joint fusion after doing a S2AI screw. I have not seen any fusing, and they all are not very happy. They all have got here and there of pain. Now, to answer your second part of question, Pavan Verma, what Dr. Pavan asked regarding SI joint pain and fusion. For me, it is an enigma. Let me admit, I don't know how that causes pain. I have tried all these injections, etc. Nothing works. And I really don't know how a fusion works there. Now, if you look at industry literature, there are papers coming and going, coming and going. I even attended workshops in North American Spine Society meeting of how it is to be fixed. But very honestly, it might be my inexperience. I don't know how that pain comes, how that pain goes. So when in doubt, I don't touch, I don't operate. So I cannot answer that question, Dr. Pavan.
Sacro-iliac joint pain, Dr. Verma, is a disease not to be treated. Okay? So,
Yes, sir.
message which should clearly go out to the residents here.
Yes.
Yes, sir.
You instrument SI joint across the SI joint for an iliac fixation. That is a different matter. You're not fusing there.
Yes, sir.
You are fusing for a sacro-iliac. The most common indication for a sacro-iliac fusions are 2 places. One is a sacro-iliac tuberculosis, where you occasionally may need it. Even there, it is rarely ever needed. Most sacro-iliac tuberculosis heal very well with fibrous ankylosis and never causes a problem. The second possibility is in a lateral end sacral fracture, where you may have to fix the fracture across the sacro-iliac joint. In these cases, you may want to do it. Again, not very common and not very necessarily needed. But for degenerative sacro-iliac joint pain, it is not a surgery which is recommended and should not be done.
Okay, sir. So next question for Deepak, sir. Deepak, sir, you have mentioned sometimes there is a pressure sore because of the screw head just underneath the skin. If it happens, sir, what we have to take care in these patients if it happens, sir?
First, you need to prevent it by creating a gutter inside the PSIS or
Yes,
putting a recess screw, or alternatively, as has shown, you can opt for S2LR iliac screws. But
yes, sir.
if it happens, then it's a very troublesome problem, and most of time, if there is a pressure sore and patient is complaining of pain, you may need to revise it. That is the only solution.
Yes, sir. Sir, one more question. Altaf, sir, because it is a extensive surgery, then what we should do the extra, especially for the pre-operative planning and the pre-anesthetic planning in these patients, sir?
One has to be very, accurate in planning properly what type of fusion I would like to do, what type of screw, what is the amount of deformity that a person has. So everything it has to be really planned. I mean, because one wrong step can lead to a lifelong disability in these
Yeah,
patients.
sir, absolutely, sir. Detailed CT scan and X-ray study.
Of course,
And-
all
Yes,
the
sir.
yes, investigations have to be done, and that is important, you know.
Okay.
Yes, sir. Gururaj, sir, would you like to highlight the pre-anesthetic preparation in these patients? Some special points.
Actually, see, mainly pre-anesthetic preparation is when we are doing in adult scoliosis, in degenerative scoliosis patients, where these patients are elderly and they have a lot of comorbidities. So actually, you will have to thoroughly evaluate them and prepare them not only physically. I could actually the most of the pain, back pain, and these adult deformity surgery, psychosocial also. So you will have to prepare in that way. And osteoporosis is the very big factor. So we'll have to consider that also. So other than that, actually it looks a very big exposure until unless you are putting these screws under the skin and which tense on the skin. The S2A screw is really safer, and it really doesn't have any increased chances of infection or morbidity. So the main special anesthetic, pre-anesthetic preparations required are in adult degenerative scoliosis surgeries, where these patients have a lot of comorbidities.
So there are two things, Pawan, which I would like to add. One is adequate blood needs to be ready because these are bloody surgeries. Number two is ICU will be required post-operatively, so be prepared with that. Number three is that your first question was very relevant. These are long procedures, big procedures, lot of muscle and bony cutting, and they cause a lot of pain.
Yes.
Multimodal pain analgesia should be given. Epidural catheters may be used, pain-controlled analgesias, patches, local infiltrations of muscle. Everything possible should be done to give relief of pain. And to all those boys who are going to do surgery for long degenerative scoliosis with the type which Ranjit showed, you must remember that these patients are never happy, even in the long term. So they will eat your head every 3 months. You have to give them Ultraset, Moveran, something. Then they'll come back after 3 months. They are not happy patients. Even if you have done a very good technically job, your decompression is adequate, everything is perfect. Surgery has gone off perfectly. But the patient quickly forgets where he started. He doesn't remember that he started at -10 and we have brought him to 0. He just wants to be at +10. And so they are never happy patients. They ruin your practice and they go outside and tell 100 people that went to Dr. Zaveri, I did not get better. So be careful about these patients when you operate.
Javeri sir,
Do you use the preoperative enema in these patients? Because many times these patients post-operatively have very difficulty in passing stools. So what we do sometimes is 1 or 2 days prior to the surgery, we give them enema or something like cremation so that they can have an emptying of the bowel. So in the post-operative period, they feel slightly more better, if you can say, because they are at least the bowel is empty for them. And secondly, I think what you said is right, sir. The patient control analgesia is really very helpful for these patients in the post-operative period because these patients have significant muscle dissection and bony dissection, and PCA is really very helpful in all these patients. We routinely provide PCA for all such patients.
Anand sir, one more thing. Have you any experience about that? The younger age group is a little bit more satisfied as compared to the older age group in sacro-iliac fixation. I have not done much. I have done 3-4 cases only, but I have observed the younger age group is a little bit more satisfied.
Because their parents are the one who are more complaining rather than the child himself. Because usually, as Dr. Ranjit sir and Dr. Gautam sir said, that it is usually the child who is having high-grade distresses in which you use the S2L screw. So, and many times if you show in the radiology, they are too happy with the radiology that what was the preoperative and what has been achieved now. But yes, a constant nagging pain is a major concern for these, even for these small children. Yes. Because as they grow, their activity increases. They go more into sports and they have more athletic activity, so that might become a concern later on. And I think Dr. Ranjit and Dr. Zaveri might be able to add a little more on that.
See, when you do a sacro-iliac fixation, especially when you are doing a long lumbar fusion, you have to remember that in the Indian context, they will find it difficult to squat for toileting, and they will find it very difficult to clean their backsides. So you must warn these patients about that also. In the children, always the body compensates. It's like you do a C1, C2 fusion in a child. It is the child has less loss of motion and is able to compensate better for this than an adult who cribs about the loss of movement. So in the same sense, children do the same, better with any kind of fusions and any kind of surgeries than do adults. They compensate better, and they learn to live with it over a period of time. So yes, I agree with you that children do a little better than than adults. Adults also, when you do a long fixation for a degenerative scoliosis, the loss of movement, they don't realize that this loss of movement is going to be a big thing. Suddenly you have lost all lumbar spine movement, so flexion extension is gone, and they constantly find the back is stiff and they don't like it. So there are lots of reasons why these surgeries are not so gratifying. We have to do what we have to do once in a while, but as much as possible, if it's a elderly patient with degenerative scoliosis, I try to manage them with conservative treatment, facet joint injections, epidural injections, exercise, and surgery is the practically I like to operate maybe one case of degenerative scoliosis a year. I don't like to do too much because these patients then keep on eating your head.
Okay.
Sir, one last question, sir. One last question.
Okay, can I add one comment to what sir said?
Yes, Dr. Ranjit. Dr. Ranjit, last comment, please.
Yeah, so like when it comes a point where I have to operate, there are two questions. You are with a painful stiff back. Do you want a less painful stiff back? If the answer is yes, surgery is there. You will never be happy forever. It will make you better. How much better? Only you can know because you are suffering the pain. If you are clear with that, we will offer surgery. If not, no. Rest all is exactly as what Zaveri sir mentioned. I do anything possible to avoid operating them. But whenever I've operated, I will not say they're not really unhappy in the very long term, because these are in their 70s. They will not be really that long enough to come back to me with a lot of pain. But in the 50s, 60s, yes, they do come back to me.
Sir, one last question, sir.
Pawan?
Sir, there was one last question.
Okay,
because
go ahead.
during sacro-iliac fixation, there is a different view of the fluoroscopy. Would O-arm will help? I have never used O-arm because we don't have here. Is there any kind of benefit of using O-arm for this surgery?
Definitely, yes. If you have an axial plane imaging, it's very useful. It's very useful. It makes your life a lot easy. But I don't have it, so I don't use it.
Okay, sir. Thank you, sir.
Thank you.
Thank you so much for so nice discussion, sir. Thank you, Altaf, sir. Thank you, Guru, sir. Thank you, Gautam, sir. Thank you, Deepak, sir. Thank you, Ranjit, sir.
Very informative.
Brilliant. It's a brilliant session by all the panelists and the speakers. And we are very grateful to all the panelists and speakers for the wonderful experience, sharing their experience and tips. And I'm sure all the delegates learned a lot of today. So let's end this session today. And tomorrow we'll move to an advanced spine course, and where there will be very interesting presentation or interesting session. It will start with MIS lift sharp at 10 a.m. Then we'll move on to the lumbar discectomy, endoscopic discectomy, keynote lectures by our legendary Professor Ramanishar and Dr. Kangtek Lim by advanced spine procedures, advanced cervical spine endoscopies procedures, and later on, very interesting presentation by legendary spine deformity surgeons of the country. So I most welcome you all the delegates tomorrow, and we'll meet at 10 a.m. sharp tomorrow. So join us with tomorrow morning at sharp 10 a.m. and good day. Thank you all.
Thank you, Jayesh. Thank you.